rocks in the coronaries, as you see on these two angios, you can see the calcium, you can see the entire coronary tree even without injecting the contrast, and always been a challenge to us. And I believe this was the last hurdle in coronary interventions which we needed to cross. Of course, we had a large amount of devices for this, and with optical coherence tomography, we were able to actually see this calcium. And if you look at from the left panel to the right panel, we found that calcium comes in different forms. Superficial calcium, then there's circumferential calcium, eccentric form of calcium, nodular calcium that juts into the coronaries, then the deep calcium. And each of this needed a different technique to tackle. They were not that easy as we thought. We had rotablation, but sometimes rotablation was not sufficient enough to tackle this calcium. Now, if you look at this particular case itself, we have a nodular calcium there. Look at the optical coherence tomography, and you find a calcium that's more or less a 300-degree arc on the left panel, and with good depth. The lumen is only around 0.9 millimeters, but the thickness of calcium itself is close to a centimeter, and that's truly a thick calcium. If you rotablate this, and we did that with a 1.5 burr, what happens actually is that you do punch a hole into this calcium, and that hole is about 1.5 millimeters. Now, in spite of punching that hole, and despite that, you still have about 500 microns of calcium. Now, this calcium needs to be disrupted before you actually can put in a stent. Otherwise, we're going to have a under-expansion. And an under-expanded stent, as we know, is a major predictor of adverse events. And this is where shockwave does come in. Remember the rule of 5, we always say, when you have an arc greater than 50% of the vessel arc, calcium thickness greater than 0.5 millimeter, and a calcium length more than 0.5 millimeter, your chance of under expansion is very high, and we need to have some form of calcium modification. The IVL system is relatively a very simple system, and I was also surprised when I initially used it. It just had a simple generator with a connector cable and an IVL catheter. The balloon itself had these lithotripsy emitters, and which actually shocked the calcium. If you look at this on the left panel, that's each emitter. And what this emitter does actually is just gives an electric energy, creates a steam bubble. And this expansion and collapsing of this vapor bubble creates sonic pressure waves. And this sonic pressure wave travels through the tissue. Surprisingly, an effective pressure of around 50 atmospheres is generated on the side of the vessel wall. And this fractures the intimal and medial calcium. Truly a revolution in the sense that if you look at this animation, you inflate the balloon to 4 atmospheres, initiate the shock wave, fracturing the calcium so that you can subsequently go and prevent an under expansion. Create a good bed for your stent to expand. Having shown you all this, let me show you some of my examples. Of course, this were some of the trials that did come on shockwave, which did say that it was safe and effective. Now, this is one of the cases that I initially did. I would probably not take this case if we did not have something like a lithotripsy with us, because there's calcium all around in the right coronary. I mean, right from the mid segment, right to distal. In fact, even wiring was difficult. An implanter and then a guide liner, balloon support. You look at the catheter, the shape the catheter takes for just the wire to go inside. And subsequently, we did pre-dilate this lesion, We put an optical coherence tomography to see what, and then it was calcium all around, eccentric, concentric, deep calcium. And I think my screen is hanging, but oh, I'm sorry, my screen has stopped. Let me try and go back.
In the meantime, I have been informed by the organizers the total of 2,783 audience participants have joined around the world. That is phenomenal.
Right. I'm sorry, but I'm going to share my screen now.
Yeah, we can see it.
You can see the screen. Great.
Yeah.
So then we gave multiple pulses with this intravascular lithotripsy balloon. And since this was my first case or my second case, and I realized you need about 10 to 20 pulses to actually crack this calcium. And post IVL pulsation, we do find a decent lumen. And the stents surprisingly went in easily after this. And we got a result that was probably decent. My first experience with IVL, this was in I think, end Jan, that made me realize that we have a revolution in our hands called the intravascular lithotripsy. Let me share another case with you before I tell you some of the messages that I wanted to give. So, expanding intravascular lithotripsy was this particular case, and there was a calcific instant restenosis that came to us after 8 years. He, of course, had chronic kidney disease. He has a stent in the proximal RCA and a stent also in the precrux RCA. The troublesome lesion here is the precrux RCA lesion. And in spite of dilating it well with an NC balloon, we still had that particular lesion there. Very stubborn, dog boning. We tried an angiosculpt. Even with an angiosculpt, that dog boning persisted. That was a lesion and persisting, and hence we decided that we're going to rotablate that. So we did rotablate it with a 1.5 burr. I was a little skeptical of taking a 1.75 burr because I realized that there is a stent inside. This was before the IVL actually came into the market. This was sometime in November or December. So after the rotablation burr, we still had that dog bone. That's what it looked like. So we did a optical coherence tomography to see what exactly was going on. And if you see this, there is calcium at 2 o'clock and 3 o'clock within the stent. So it's not an under-expansion of the stent 8 years ago, but it's new atherosclerosis with calcium within this particular stent. You can make that out here, right again here, between 3 o'clock and 2 o'clock position. Calcium remaining there, very stubborn to dilatation, to an angiosculpt and to a rotablation. So at this point, what we normally did is we thought we had the best result possible and we left him. The reason I'm showing you this is to show you an under-expansion is a problematic thing, because 4 months later, he did come with unstable angina, luckily, and this is what we see. We have ISR proximally 2, but distally, we have that under-expansion causing a stent thrombosis. That's what we made out on optical coherence tomography. If you see as the run goes on, you see that calcium there, and you see a distal part, extensive thrombus around the under-expanded stent. So that's a problem that you do find when you have calcium and you leave an under-expanded stent over there. So this time we had this, as I said, the new kid on the block, and that was the intravascular lithotripsy. And we gave a number of pulses, and we were able to get a crack on that calcium, and subsequently a high pressure balloon, opened it easily, could put a good stent inside, and we got a good result. And if you look at the lesion, it's expanded. That was what the OCT looked like before we did the IVL and the stent in. Look at the eccentric calcium on the lower panel with an MLA of 2.93, which expanded to the decent 7.44 millimeters minimal stent area, exactly at that area of calcium. So undilatable calcific lesions are an Achilles heel, and the stent expansion, as I said, was a major predictor of MACE. So intravascular lithotripsy did help us in improving MLA in this particular lesion. Now, this is another case in which a rotablator assisted an intravascular lithotripsy. If you see this calcium in the proximal LAD, we initially were not planning to use IVL. We thought just a good high pressure balloon would do. But then we realized that a 1.5 balloon was going into difficulty across the lesion and that was not dilating. And at that point, we went in with a rotablator and we created a channel across that with a 1.5 rotablator, creating a sufficient channel for us to go and dilate. But when we did the optical coherence tomography, we did find that there was quite a thick eccentric calcium over there. And it's pretty big. The rotablator has punched a hole of 1.4 millimeter, as you see there. Quite a perfect round rotablated lesion there, but a huge eccentric calcium of more than 1.5 millimeters over there. So at this point, we thought if we go with a stent, we're not going to get a good expansion. We did a IVL balloon, tracked easily. So another point, if your OCT catheter goes inside or after a rotablation, IVL tracks very easily. And we gave a pulse, got a good result, and the stent did deploy extremely well in spite of an eccentric calcium. So that's my last message to you. For a tight calcified lesion, an IVL balloon is not likely to cross because it is bulky. So rotablation will help the IVL cross the lesion. IVL helps breaks this and helps expand the stent to an adequate size. So these were some of my cases that I wanted to tell you about this new revolution that we have of shockwave to modify calcium.
Thank you, Dr. Ronnie. And let's have a quick comment from Dr. Sanjog. Sanjog, you have been involved in chip cases. So let's have a quick comment from what is the state or what is the place of IVL in your cath lab?
Thanks very much. Yeah, those were beautiful cases and optimal demonstrations of this technology. I think that I agree with Dr. Matthew in that IVL is truly here to stay, and it's not just available and functional in the coronary space, but also in the peripheral vascular space. So what it is allowing is us to tackle some of these otherwise difficult lesions where the technology that we had previously was good, but not great. There was a case that we did a little while ago where we had 3 layers of underexpanded stent in the left main in a guy with an EF of 30%. The iliacs were horribly calcified and we couldn't get a hemodynamic support device up, knowing that we would have to have a high pressure balloon inflation done in the left main for an extended period. So we used IVL to take down the calcium in the iliacs, deliver a long sheath, deploy a support device, and then used high pressure ballooning and in fact also a coronary lithotripsy device to be able to get excellent expansion. So it's an example of a technology that is helping us deal with problems that we recognize, but that we have never had quite perfect technology to deal with before. I think the future of this technology is going to be getting it more widespread and then making it easier to deliver. There are fundamental issues with the technology that make it more challenging to deliver just because of what it does. And as Dr. Patel pointed out earlier, technology iterates. It gets better and better with time, and this is a company that has legs. So I congratulate you on those great cases and the use of this technology. I look forward to more.
Castrati, your views on this? Please unmute.
It's a great technology, as I see. I said yesterday that we still don't have it. We plan to have it in the next few weeks. I have only one question. Does this technology modify the vessel wall response at follow-up? Are they studies, OCT studies, angiographic studies? What's about the muscle cell reaction to this technology?
Yeah, I think that's a very good question, but I do not have an answer to that. I do not think we have an OCT long-term follow-up of these cases. All that we know is the acute results are brilliant with no short-term effects, and I think we must point out over this, as far as compared to a rotablator, we do not have slow flow. We can do it in hemodynamically unstable patients with no risk of perforation or dissections. But as you said, a long-term result is not known yet.